مساء الخير. Thanks for inviting me. Thanks, Dr. Rasha, Sam. Thanks, Dr. Rasha Kamal, and all the team. And thanks for organizing this very nice workshop. I really enjoyed the past lecture. I will talk about treatment of breast or managing breast cancer during pregnancy. These are my disclosures. So I'll start by one real case that I had. A 33-year-old lady, negative medical history and no family history. She presented to me with a growing breast mass that's painless, and she's married and pregnant 13 weeks. That's her first child. On clinical examination, the mass was more than 5 centimeters, so it's large, upper outer quadrant, and no palpable axillary lymph nodes. So first of all, can we do any imaging studies during pregnancy? So, ultrasound, of course. So she did ultrasound, and that's usually done for the first time by her gynecologist, because many of the patients who are diagnosed with breast cancer during pregnancy, they do the first ultrasound with their gynecologist during the antenatal care. So the mass was around 4.5 centimeters, and the lymph nodes appeared reactionary. That was, of course, done by a breast radiologist. And the mass was biopsied, showing an invasive duct carcinoma, grade 3, triple negative. That's bad. And the Ki-67 of 40%. So that's an image. That's a poorly taken image from the report. But so now the next step that we usually do in our MDT is to see that any other tumors other than that or not. Where typically we do mammography with the ultrasound, but that lady did not do it because she's pregnant. And in some cases, of course, we need additional imaging that's suggested by the radiologist member of the MDT, which is probably MRI, contrast enhanced, or a contrast mammography. And those also are not done. So what do you suggest to rule out multicentricity? We might start with her with a neoadjuvant therapy, and our surgeon need to plan the surgery ahead. So how to rule out multicentricity in that lady? Yeah, I see a lot of you saying, no way. But and that's the truth, because, well, not regarding safety, but mammography can be done during pregnancy. Abdominal shielding, and it's a low dose, so usually it's safe. And at that time, the fetus is all in the pelvis, so it's far a little bit from the breast. However, the problem is not safety. The problem is its use, because, well, I see some of you can tell me there's something inside this breast, but again, for us and for the surgeons, we see nothing in those mammographies. And with evidence, we have a false sensitivity rate from 60 to 70%. And this means that we miss around 30% of the lesions. And if you're looking for a multicentricity, you're looking probably for smaller lesions that are more likely to be missed. Breast during pregnancy is enhanced with glandular tissue that is secondary to the progesterone, and that's why mammography gives less information. So that's why we usually don't do mammographies, and that's why most of you said no, because when it's not helpful and when it carries sometimes some medical legal issues, you don't want to take the risk because you'll not add a lot. So we counsel the patient then that, well, it appears that she has one tumor, and she might be a candidate for breast conservation, but we're not 100% sure, as we can do the regular imaging. So that's the risk that she have to take if she's willing to keep the breast. So MRI, can we do MRI? There's no radiation in MRI. Of course, the contrast is the problem, and well, MRI without contrast, I'm sure most of you would say it's useless, so we do not do MRI, of course. So the MRI is safe, but the gadolinium is not. So we will stay with the risk of having another additional lesions, but with the clinical and radiological picture or ultrasound picture showing a unicentric mass. So she is potentially candidate for conservation, taking that risk. So staging workup. Well, cancer at that size might have metastasis. What to do to rule out metastasis in those in pregnant ladies? Ultrasound board. Good. Well, ultrasound is safe, we know that, but you can do only ultrasound for the liver. It might be less sensitive, of course, compared to contrast CT for the liver, but liver metastasis at presentation is really very rare. So ultrasound is not only safe to rule out liver metastasis, but it is effective. The difference between ultrasound and contrast MRI or CT in an unpregnant lady with stage 2 cancer is almost nothing. So there is no problem to do a good ultrasound. That's the main part. But okay, now we've solved the liver problem. But well, bone metastases are much more common than liver metastases, and lung metastases are much more common. So what to do for them? First of all, staging should be the general rule. You limit that to the least possible exposure, and you should avoid the contrast material. Again, CT contrast and MRI contrast are known to be teratogenic, and that risk is there even after the first trimester. Please note that our patient is at the end of her first trimester and the beginning of the second trimester, not very safe. So CT scans with contrast should be avoided. Regular PET-CTs, bone scans are better avoided. However, we have the list on the right side are the relatively safe list. Chest X-ray, it's a low-dose study. It can be done to rule out large lung metastasis and pleural effusion. Well, but that's all what you get with simple chest X-ray. Abdominal ultrasound, that's very good. That's enough. And we have modern low-dose PET-CT protocols. That's non-contrast. That's very effective in ruling out metastasis, much more effective than the chest radiography, for example, especially with difficult sites like the chest and abdominal lymph nodes, for example. So it is safe. There have been some studies supported by many cancer centers and nuclear medicine centers to clarify this point. Even bone scans in patients with high risk. We don't do bone scans in patients who do not have bony pains. But if you find a patient with symptoms suggestive of bone metastasis, you should do something. You can do a non-contrast MRI on the site, or you can do a low-dose PET-CT without contrast. That's possible. The fetal exposure of the low-dose PET-CT is around having 4 hours flight twice, back and forth. That's the kind of exposure you get from the low-dose PET-CT compared to the regular flights. It might come out to be non-metastatic. And for another reason, the bone scan does expose the fetus to the radiation through the bladder, because the distribution of technetium does not affect the fetus. So if you put a urinary catheter to remove the urine collection, you give very low exposure to the fetus. So that's what we did. So we chose to do a simple chest X-ray and abdominal ultrasound, and that have much less exposure. She didn't have any symptoms suggestive of bone metastasis, so we did not request bone scans or PET-CTs. So, but our patients asked very relevant questions. So how come that I get breast cancer during pregnancy? It's well known that pregnancy and lactation is protective against breast cancer. They all say that. So I got it during pregnancy, and that's not, it's said that it's protective for life, but it didn't work for me. Could the diagnosis be wrong? That's the question. Because, you know, if you talk to a lot of patients, many do not believe that breast cancer can come during pregnancy. Second, so they say that breast cancer, when it comes during pregnancy, it's very poor prognosis. So it's like when it comes there with the hormones, with everything, then the cancer progresses and metastasizes very fast. Is that true or not? Well, first question, can it happen during pregnancy? Yes, but it is 1 in 3,000 to 1 in 10,000 pregnancies. Our patient was very unlucky, but it can happen. If you compare any cancer that can come during pregnancy, breast cancer is the first. And the definition is not only cancer that can happen while the fetus is in. It's pregnancy-associated breast cancer. The term, it means breast cancer diagnosed during pregnancy or during the year following delivery. Median age is 33 years, and that's like the median age of pregnancy or something. Does pregnancy protect against breast cancer? That's a risk. Well, it's well known that the risk of having breast cancer is more in the nulliparous, where she had no pregnancies, compared to the multiparous. This information is not as simple. If you look at that graph, the horizontal line is the risk of the nulliparous, okay? While we consider high, right? That's the age-adjusted incidence. So if you look at the first line going down, that's if the lady had the first pregnancy below 20 years. And the red line, if the first pregnancy was below 25 years. What happened at the curve? At the young age, you have a peak at the 20s and 30s. So this pregnancy, the early pregnancy, it does protect against the post-menopausal breast cancer. So her risk to get breast cancer at older age is less. But compared to the non-pregnant, 25 years old, her risk to have breast cancer is more. So what if pregnancy happened after 35 years? That's the last line. The risk around the 40s is higher than the nulliparous. And it never comes to the nulliparous risk. That's very important to think of. So early age of pregnancy protects against having breast cancer at elderly age. So what about the prognosis? Is it bad to have breast cancer during pregnancy? It's bad to have breast cancer at any time, but during pregnancy, does it make a difference to other breast cancers without pregnancy? Well, that's a retrospective series of more than 300 ladies that were compared to more than 800 ladies who were non-pregnant breast cancer. So those compared 300 pregnant breast cancer and 800 non-pregnant breast cancer. And the hazard ratio of having pregnancy while diagnosed with breast cancer, well, hazard ratio is related to death or of relapse. So it's 1.34 with non-significant p-value, and also for death, 1.19, meaning that there is no major difference between those diagnosed during pregnancy and those diagnosed without pregnancy. So, again, does this mean that the prognosis of our patient is good or equal to a 60-year-old lady with same cancer? The answer is no. She has worse, but not because of pregnancy, but because of three main reasons: locally advanced disease, young age, and triple-negative breast cancer. And why young age does count? This is survival curves of ladies having breast cancer. The red line is if they got their breast cancer below 40 years, and the other lines 41 to 50 and more than 53. The lower line, this is survival curve, so the lower line is the risk of having relapse. So if you have lower line, you have more relapses, meaning that having breast cancer below 40 years carries worse prognosis compared to having it above 40 years. And because most of the pregnancy-associated breast cancer occur less than 40 years, so you expect this bad outcome. Again, not because of pregnancy, but because of age and the biological subtype that the patient is diagnosed in. So Our patient, clinically T3 and 0, M0, triple negative breast cancer, and at the beginning of the second trimester. What do we give her? First of all, would we do what we call therapeutic abortion or not? Do we take out the baby? No? Who says yes? Who says no? Okay. If you had surgeons in the room, the answer would be opposite. Okay. So that, well, and that's because of why? Why don't we take out the baby and start giving her surgery and chemotherapy? Yes, that's a short answer. But let's ask the first question. Well, you might have some treatments that doesn't go well during pregnancy. But first of all, does the termination of pregnancy improve the outcome? Well, I've heard that pregnancy got a lot of hormones. And this is breast cancer. They don't like hormones. Or the cancer like the hormones. Should we terminate the pregnancy to bring down the hormone levels to the normal? And so we treat her like the normal non-pregnant lady? Well, the answer is no, and that's based on evidence, meaning that if you compare those ladies who opted for termination for any reason to those who said, I will continue the pregnancy for any reason, the prognosis is similar. And you have also some data that might have better survival associated with keeping the baby. We're not sure of that, but at least it does not improve the survival to terminate the pregnancy. That's of the therapeutic value of abortion. There is nothing called therapeutic abortion for breast cancer. It does not cure cancer better if you terminate the pregnancy. So, sometimes in early disease, in advanced disease, very early in pregnancy, in the first trimester, you might have the decision to terminate. You must discuss with the patient the decision to terminate the pregnancy, not to improve the outcome, but to allow for therapies that cannot be given during pregnancy or that is teratogenic to the baby. Again, some patients opt to keep the baby and take the risk. And again, if you look at the teratogenic risk of most medications, this is not thalidomide, okay? The treatments that we're giving, it causes, of course, any treatment can potentially cause a teratogenic risk, but that's not like, in the worst case scenario, it's around 10%. So if she's communicated the risk of every treatment she's given, she might choose to take the risk and keep the baby. So management, as a general rule, we follow the same rules that we take during the non-pregnancy, with some exceptions, adjusting the treatment. First of all, chemotherapy. That's a triple negative breast cancer. The best treatment for her is to receive neoadjuvant therapy, then go for surgery. Can we give neoadjuvant therapy, neoadjuvant chemotherapy during pregnancy? Well, it depends on the teratogenic risk. And to get that teratogenic risk, we get patients who got the chemotherapy by accident. We didn't know that they're pregnant, so we should do pregnancy tests, but sometimes we forgot. So we did the chemotherapy, and then she feels some baby moving in her belly, because a lot of them has amenorrhea. So when they discovered the pregnancy, when they found the baby kicking. So most of the drugs, which is relatively, chemotherapies are usually small, so they cross the blood placental barriers, so they happen to affect the baby. But other thing that the pharmacokinetics of the chemotherapies during pregnancies and of all drugs during pregnancy is different, because there is a hyperdynamic circulation, increased plasma volume and increase the renal clearance of the drug. So the peak might be higher than the drug is cleared faster. So it's different with every drug that you're giving. So the most important period for the organogenesis is the first trimester. So if you're giving any treatment, any medication, as a general rule, you should avoid the first trimester. In the second and third trimester, the baby is almost full. It's just growing. So with that, the tolerance of the fetus during the second and third trimesters to the majority of the medications is very similar to the adults or to the child after is born. So you're giving medications to the 9 months old fetus, so you can also give it to the 6 months old fetus. So that's anthracyclines. That's the most famous medication that we're given. If you're not aware with it, you can just ask the patient if they got the red one. That's the red chemotherapy. And if you give it at the first trimester, you're associated with around 20 to 30% of abortion and 10 to 25% of malformation. That's bad. But after that, you can have some problems that can be managed. So around low birth weight, 1 every 5 or 2 every 5 babies, and a little bit higher rate of miscarriages. But generally, no detrimental effect on the functions or the gonads even. This is a series of patients who were exposed to anthracycline, whether by accident, as I told you, or they chosen to take chemotherapy and take the risk. So if you look at the number who received chemotherapy, there are 51%. And anthracycline, most of them. How many got that's also for taxanes. And if you look the gestational age at delivery, it's a median of 36 weeks. So they tend to deliver earlier, and they tend to have smaller babies. It's 2.4 kilograms if they received it during pregnancy. Again, not a big deal regarding the malformations. Supportive treatment, you should adjust the antiemetic therapies and steroids because, they also have some side effects during pregnancy. But as a general rule, even G-CSF support, it can be given. So it can allow even giving chemotherapy every 2 weeks, what we call a dose-dense chemotherapy. And we might need that in triple-negative breast cancer. So chemotherapies are usually safe to be given, and hormonal therapy is contraindicated during pregnancy, and that's the opposite of what the patient thinks of. The hormonal therapy, which is the less toxic medication, interferes with many of the growth of the fetuses, but not the majority of chemotherapy. Of course, some chemotherapies are contraindicated. Monoclonal antibodies, they are not indicated. So if she's HER2 positive, she cannot receive trastuzumab, which is very important during pregnancy, and if she's triple negative, like Our Lady, she cannot receive the new immunotherapy, pembrolizumab. But at that time, we did not have the pembrolizumab approved, so we cannot give it anyway. That's a little summary of what to do if the lady was diagnosed by breast cancer at every trimester. First row, first trimester. What to do? She can go for lumpectomy, breast conservation, or mastectomy, whatever her treatment is, whatever her possible treatment is, and the axillary lymph node dissection can be done, of course. And adjuvant therapy, adjuvant chemotherapy can be delivered during the second trimester safely, and the radiation therapy and endocrine therapy can be delivered after delivery. If she is diagnosed during the second trimester and early third trimester, like our patient, she could go for also upfront surgery with the same as above, or the reverse. She could receive the neoadjuvant chemotherapy, like we suggested for our patient, followed by surgery that will be very near to the delivery, and she can go for the post-operative radiation therapy and endocrine therapy later. And if she is diagnosed at the third trimester, well, that's the easiest. The pregnancy is almost done. So she gets either radiation therapy or start the first 2 to 3 doses of chemotherapy, then delivery, and continue your plan as you think. The last question posed by our patient. Now I got cancer in my first pregnancy. Can I have second pregnancy without having more risk of recurrence or not? Well, the first pregnancy was really bad luck, but can she go for a second pregnancy? What do you say to her? Well, we have a meta-analysis of 14 studies. Those are observational studies. We cannot randomize patients. You go pregnant and you do not. You just let them choose, but you follow them, whether or not you can give the pregnancy. And this is, in short, it appeared like having, in this study, it appeared like having pregnancy was associated by less mortality and less relapses. Again, we don't know if that's a coincidence or that's a confounding bias, but at least we can reassure our patient that if she had further pregnancy, it's not associated with poorer outcomes, not mortality and not more relapse. We have now, that's a survival curve for those who went for pregnancy and those who did not. And my conclusions, breast cancer in pregnancy is a special entity. It should be managed by expert MDT. And breast cancer in young age carries a poor prognosis than the older counterpart. That's a risk that should be well noted. And personalization of treatment strategy in pregnancy with breast cancer is a must. The treatments of breast cancer should adopt the regular standard of care with taking the patient's peculiarities during pregnancy into consideration. And thank you very much. Do we have any questions? No? Nice. We're short of time anyway. Thank you. Dr. Ashraf?